All right. So I am so excited to be doing this presentation with three of my incredible medical student mentees, Alyssa, Laura, and Rachel. All of them are just wonderful. They do so much advocacy work, and it's quite a pleasure to be able to do this with them. And our goal for this presentation for today is to be able to talk about what are the important things that healthcare providers need to know about. And more importantly, for those of you that aren't in healthcare, what are important things that you should be aware of that you can ask your healthcare providers about? So, just to give a little bit more information to all of us, so I'm currently a fourth year orthopedic surgery resident in Modesto, California. You'll meet everyone on this talk here with their slides. So Alyssa is currently a third year medical student at Touro College of Osteopathic Medicine. Laura is a third year medical student at SUNY Upstate Medical University. And Rachel is a fourth year medical student applying to orthopedic surgery this cycle, who goes to Edward via College of Osteopathic Medicine. So for our workshop overview, we're going to talk a little bit about what is domestic violence. We're going to highlight some of the orthopedic manifestations. We're going to talk about what are some of the healthcare professional responsibilities and what are screening tools that we can utilize as healthcare professionals. What are some of the interventions and prevention modalities that we can utilize? And then close off with a summary. And just to highlight the importance of this workshop, everyone that is here today, thank you again for taking the time. Again, intimate partner violence is something that can affect anyone. And to be honest, throughout medical school, it's not really taught very well. Most of the time, it's only a few small lectures here and there. And so oftentimes physicians and other healthcare professionals really don't have good training. And unless they themselves have been affected by intimate partner violence or know a loved one or have a experience working with individuals in those scenarios, they oftentimes don't know how to respond to look out for signs of intimate partner violence. And so we hope everyone in this audience can hopefully take some of these tools and maybe even share them with some of the healthcare professionals that help take care of them and their loved ones.
Hi, everyone. Thank you, Dr. Rasmussen. I am honored to be here today and to talk about this very important subject. So let's get started. So I believe we've already touched this with Mariah and Dr. Rasmussen, but according to the National Coalition Against Domestic Violence, around 10 million people in the United States annually are affected by domestic violence. So what we wanted to establish here is that domestic violence is not just physical violence, like we've mentioned before. It encompasses different forms, emotional, economic, psychological, and technological, like Dr. Rasmussen touched on. Um, and these statistics kind of range between different resources and different organizations, but anywhere between 1 to 4, 1 to 5 women are affected by partner violence, and anywhere between 1 to 5 and 1 to 9 males are affected. Now, these organizations can list it as female and male, but they're not specific as to, sex, gender, and we know that when you divide it into those further categories, things can get a little bit more specific. But males have been historically underrepresented because of the stigma around social constructs within this country specifically. So our purpose here is to shed a little bit of light on the role that healthcare plays by using data provided by survivors themselves. So I'm sorry. My messages are going off. Okay, our purpose, so here I just wanted to talk a little bit about a study that was done on female survivors in 2006 that identified that intimate partner violence is the most common cause of non-fatal injury in women. So we need to recognize that the first place of contact for a lot of these survivors is within the emergency department setting or orthopedic clinics during follow-ups. Next slide, thank you. So the PRAISE study, which is an incredible cross-sectional study, which means a study done at one point in time, was done in 2010 that studied orthopedic fracture clinics across Canada, the United States, the Netherlands, Denmark, and India. And they established that, 1 in 6 patients disclose a history of intimate partner violence in the past year, and that 1 in 3 have experienced it in their lifetime, with women in the United States and Canada actually reporting it at a higher risk of abuse in their lifetime when compared to Denmark and the Netherlands. Thank you. So this study was done by JBJS, which is actually a very well-known journal within orthopedics that further established that 1 in 50 women presenting with injuries to an orthopedic clinic would have been the result of intimate partner violence. So the most common injuries that we see are head and neck injuries, but those that follow are musculoskeletal injuries, which can include sprains, fractures, and things like foot injuries. So this highlights the importance of orthopedic surgeons to actively screen for signs of abuse in these settings because some survivors might not disclose this for fear of retaliation from their abusers. So, finally, this review highlights the way that providers can identify and intervene on behalf of the survivors. So, screening for domestic violence can occur in the primary care setting, as the United States Preventative Services Task Forces kind of deals with these screenings at a level for women of any reproductive age. But knowing that 1 in 3 women who present to orthopedic fracture clinics have experienced IPV within the last year should open a pathway of screening within the realm of orthopedics.
Thank you so much, Laura. And hopefully, all of those statistics once again highlight that this is not a situation of us versus them. This has prevalence everywhere across the country, and it is oftentimes, as Mariah highlighted, silent and very hard for people to know what might be going on. So, from the orthopedic perspective, this is something that currently, in my residency, we haven't had actually any formal training, and that's not unique across orthopedic residencies. This is not something that is typically well taught regarding how do we screen for and understand intimate partner violence. So oftentimes, patients don't feel comfortable or they feel very embarrassed sharing what happened, especially in scenarios of intimate partner violence. So some of the things that can be very helpful is talking to the patient alone. Let's say that you are someone who is experiencing this, or you know someone else. A very helpful thing you can say is to tell the physician, tell the nurse practitioner, whoever is seeing you, is it possible that we can talk in a private room or do something so that you can be one-on-one with that provider? Or maybe you're in the scenario where you don't feel comfortable because maybe it's a male provider or someone that you don't feel like you have good rapport with. You could always ask for a chaperone. So whatever it can be to help improve that transparency and communication and trust will be very helpful. Importantly, from the physician standpoint, it's important that we assess for recurrent fractures or injuries. Fractures is the medical term for saying a broken bone. They mean the same thing. And like Laura was saying, oftentimes patients will have a sprain here, another sprain. Oh, I tripped and fell. And it starts to become this story where it seems like something more is going on. And from the healthcare perspective, sometimes we feel uncomfortable asking those questions, especially if we haven't had training. We are afraid of saying the wrong thing. We don't know if we're going to offend someone. And so it's really important that we all recognize that it's not just the patient's responsibility to bring up their concerns or if something's happened. It's really on the rest of us to have that bravery to ask those questions, even if we might feel uncomfortable. And recognizing that screening is underutilized. We'll talk a little bit about some of the screening modalities in the next few slides. And ultimately, intimate partner violence is underreported, and it's something we should always keep in the back of our minds whenever we see any sort of trauma. And so ultimately, the goal is we want to figure out what are screening methods that we can utilize that are going to be safe and easy to use within the healthcare setting, and use this to help with referring patients to get additional support, especially with us wanting to create a safe space for that our patients to be able to ask us questions if they feel that they are comfortable disclosing what might be occurring. And so, as healthcare professionals, our responsibility is one to recognize signs. If we have a patient with unexplained injuries, often they have frequent emergency room visits. One of the most common things that's actually not orthopedic related is recurrent abdominal pain. This has been seen in the literature that very commonly individuals that are experiencing intimate partner violence struggle a lot with things like inflammatory bowel syndrome, abdominal pain, and that can oftentimes manifest as a lot of anxiety. And so sometimes these kind of vague symptoms can actually be a sign of underlying intimate partner violence or the patient literally being afraid of going home and they're afraid to be able to share what's going on. And so, importantly, thinking about screening, that can be very helpful, and especially in the primary care setting, in orthopedic clinics, OBGYN, and emergency departments. From the healthcare perspective, we want to make sure we're documenting carefully, thinking about if there's any important photos. For example, some of the electronic medical records, such as Epic, you can take photos. So you always ask the patient's permission. Things like bruises, all of that can be very helpful, especially if that person ends up having physical manifestations of intimate partner violence and wants to showcase that in potentially in the future for any sort of law enforcement. We want to make sure that we're ensuring safety for all of the individuals that we're interacting with. So, knowing some of the referral resources, we'll talk about some of them throughout today, and making sure that we don't confront an abuser or someone that we suspect to be an abuser in front of the patient. This is where it's really on us. If we have any sort of red flags going off, that we say, hey, this actually part of this conversation needs to be one-on-one. I'm going to have you wait out in the lobby, and making note of doing things like that. And then importantly, it is reporting. We have safeguards in place for children and for elder abuse, but we really don't have a lot of public health safeguards outside of a lot of nonprofit organizations for when we suspect domestic violence, unlike things such as child protective services or elder protective services. And so it's important to recognize that there are a lot of great community resources out there, and that sometimes the best resources aren't necessarily getting law enforcement or other people involved if that individual isn't there yet. Sometimes it's just helping that person recognize here are some resources out there, and whatever steps you want to take, I'm here for you because I want to give you that control of where we go next.
All right. Hi, everyone. I'm Rachel. Thank you all for the time and space to have this conversation and have this event in the first place. But I'm here to talk screening tools because a lot of times, as physicians, when you start to have conversations like this, it very quickly can derail, or you end up walking out of that visit and thinking, I didn't ask this, this, and this. I missed a lot of important information that I could have had with the patient right in front of me. So screening tools, like any other screening tools we have in practice, helps account for everything that we want to know when we have the opportunity to have these kind of conversations. And so the first one is the acronym is HITS. It stands for Hurt, Insult, Threaten, Screen. It's a 4-item tool validated in primary care. And my point in this slide is this is common knowledge. You can look up these screening tools, and if you don't know how to navigate conversations with your family members, with your friends, with your peers, with anybody, this can also be for you. It's not just for physicians, it's just what we establish for ourselves, but it's for everybody to use. And so that's my note on that. The next one is WAST, the Women Abuse Screening Tool. It's a brief questionnaire designed specifically to detect abuse within intimate relationships. It's not just physical violence, but emotional, psychological abuse as well. It begins with 2 simple questions about tension and conflict in a relationship. And if those responses suggest concern, a tool continues with 6 more detailed questions that probe specific abuse behaviors. And so this structured approach guides the provider and also helps patients feel more comfortable. RADAR is an easy to remember framework. It stands for routinely screen every patient, regardless of demographics or appearance. Ask direct, kind, and without judgment questions. Document your findings carefully. Assess the patient's immediate safety, and review options with the patient and make referrals to appropriate support services. It's powerful because it reminds us that asking about abuse is not just a one-off question. And so that leads me to say asking non-judgmental questions is crucial because these screening tools, there is a skill of asking non-judgmental questions that come with it. It means that we use open-ended neutral language. Instead of asking, why don't you just leave your partner? We might say, can you tell me about your relationship? Or are there times where you feel afraid at home? It just normalizes the discussion by explaining questions about relationships are a routine part of care because abuse is unfortunately as common as Laura described. So when it comes to intervention, we have, domestic violence involves 3 key stages: Primary intervention prevention occurs before the violence happens, and it focuses on promoting healthy relationships, especially in our adolescents, providing anticipatory guidance in pediatric and adolescent medicine. Secondary emphasizes early identification, screening patients routinely, and building safe, trusting environments. Tertiary prevention aims to reduce the long-term harm by connecting survivors with community resources, shelters, counseling, hotlines, to name a few. Developing a safety plan in collaboration with the patient is an essential part of the tertiary care. Partnering with social workers and advocates make these interventions much more effective. And then when it comes to intervention, the CUES model stands out as an evidence-based approach to addressing the domestic and sexual violence in healthcare settings. CUES stands for confidentiality, universal education, and support. Confidentiality is critical. Know your state's reporting requirements and be transparent with patients about limits to confidentiality is of utmost importance for physicians to be aware of when we're dealing with our domestic violence patients. And so this slide just highlights the crucial importance of confidentiality when it comes to addressing domestic and sexual violence in healthcare settings. Universal education is that other aspect. Give each patient 2 safety cards or ask them to send a link to resources to start conversations about relationships and how they affect health. And so sometimes you don't know how to help your patient if the patient doesn't know what you want to know. And so with any other kind of disease process or things we manage in the office, educating the patient is almost half the battle so that they understand what you're looking for and why you're asking the questions that you're actually asking. And then support. Through disclosure of violence is not the goal, it will happen. And so know how to support someone who discloses. A lot of times navigating these questions are either a hit or miss thing. Either they feel comfortable opening up to a complete stranger if it's your first visit with a patient. Other times they need someone to have an established relationship with. So regardless of where you are in your physician-patient relationship, supporting them as best you can is really something that you have to be aware of.
Yeah, and so my name is Alyssa, guys. Thank you for having us. Just wanted to highlight this slide here, just has some resources here for you guys. If you want to scan the QR code, we'll leave it up for a minute. And we also have some numbers attached for you guys. Again, giving these resources to patients is something that's part of the job when you're a physician, and just supporting them along the way, creating that space where people feel like they can be heard and comfortable. It comes with the job, and it's a special thing when you do connect with people and allow that space for them. So please take these resources and share them with others.
All right, so just some final thoughts, and the handout QR codes are here on the right. So for final thoughts, domestic violence can affect anyone, regardless of if you're a physician or you're someone who is a single mom. All of us can potentially be affected by this, whether it is ourselves or a loved one or someone that we're helping care for in the community. It is essential that healthcare providers are acting as key liaisons, that they are educators and they're advocates. And once again, medical school residency oftentimes neglects to teach us how to be good advocates and doesn't always teach us how do we interact with someone who's going through intimate partner violence. And so if you can take that, if you've had a negative experience with the healthcare system, I hope you can take a step back and maybe give that healthcare professional a little bit of grace and maybe recognize that they probably just didn't get good enough training. Now, that doesn't justify you not getting good care, you feeling dismissed. But my point is that if you empower yourself with some of these tools and you share it with other people, they may be able to actually help educate those in the healthcare setting to then be able to help other individuals. And recognizing that most people, when they're experiencing intimate partner violence, they're going to feel afraid or ashamed to ask for help. And there's oftentimes the misconception, which once again, I at one point had until I experienced it myself, which is why don't they just leave? But in reality, not everyone has the financial ability to be able to leave. Not everyone is able to be independent if they were to leave. And sometimes the emotional coercion is so powerful that that person truly believes that if they were to leave this unhealthy relationship, they would not be able to find someone else who would love them or be able to find support, or maybe they would lose stable housing, or their child would no longer have a healthy father role model or a healthy mother role model, whatever it may be. And with that, sometimes people aren't necessarily ready to get help. Our point is not to tell someone, you need to go to the police, you need to do this. Try to work on giving the people a sense of control. Give them back what has been taken from them. Allow them to feel like you are their advocate and let them learn about what those resources are, and they can decide on their own terms when they might want to make a change. Maybe they don't do that for a long time. Maybe they never do. But your job is not to be judgmental. Your job in the healthcare field is to be an advocate. And sometimes you might be the first person to identify a sign of domestic violence. And remember that domestic violence is not just physical, which is often what is thought of when we think about intimate partner violence. More common than not, the intimate partner violence is not someone having a massive trauma and tons of bruises and broken bones. More often than not, it is someone who has a lot of ankle sprains or someone who has that recurrent abdominal pain that they can't quite explain. They keep coming back to the emergency room with these vague complaints. And so, once again, taking a step back and being curious and really allowing ourselves to try to learn from our patients as well. So, with that, the main takeaway is it is on all of us to work together to help everyone that might be experiencing this and those in our community. Here are some of our references. And thank you all so much for taking the time to listen to us. I feel very fortunate to work with such incredible medical students that are trying to help improve healthcare training, because I know when they become physicians, they're going to help educate others on this topic, which once again is not readily taught very well in medical school and residency training. So thank you all for taking the time, and I hope you all have a wonderful rest of your day.